Good morning. It's a bit of a tag session between Colin Edwards from the North Shore and myself at Auckland. And we've been given the topic primary prevention in cardiology. So that's a pretty big topic, and we'd like to just start off by reminding people that lifestyle methods are highly effective, provided you engage in them. And really the lifestyle methods can be summarised as so. There's a heap of data demonstrating that these lifestyle approaches are helpful for prevention of cardiac or vascular problems. The main medical methods of prevention can be summarised as well, and these are they. And really it's a huge topic, and we've got 25 minutes with a couple of questions at the end, so we're going to focus on blood pressure and cholesterol. And for those who've come from outside of Auckland, welcome to Auckland, and this is our tag session on primary prevention in cardiology, lowering blood pressure and cholesterol and calcium scoring. So I'll just move over to Colin. Thank you.
So once again, welcome everyone, and I'm sure you'll find this an enjoyable session. I'll go straight into a case which is a young chap that was referred to us, a 48-year-old gentleman called Johnny, who was an electrician, and he was of Maori ethnicity. He enjoyed going to gym, but didn't really look after himself that well, and he did himself an injury which lingered, and so he thought after a while, in fact his wife probably prompted him to go and get it checked, and so he was seen by his GP and had a full examination and 5-year cardiovascular risk assessment. And as you can see, he does have a whole raft of important cardiovascular risk factors. The fact that his father had an MI at the age of 50 is a great concern because he's approaching that age now. He was found to be hypertensive on 2 readings while he was at the GP. Blood pressure 140/90, and importantly his father had quite impressive hypertension as well, so there definitely is a familial tendency there. He used to smoke, fortunately gave that away a few years ago, and by BMI it fits into that obese category. His HbA1c on this occasion down to 41, but previously in the mid-40s, and as you can see he does have a dyslipidemic profile there, with a lowish HDL and a raised LDL, triglycerides of 4, perhaps reflecting his dietary habits. And he tries to sort of do a few walks a week, goes to gym a couple of times, and admits that there could be a lot of improvement in his diet. And so the referral, so this was his risk assessment, and one can see, putting in all the various factors, that he comes out at an intermediate risk between sort of 5 and 10% there, 9.4 to be more accurate. But so that would be an intermediate risk. The current guidelines suggest that anything less than 5 is low, 5 to 10 intermediate, and over 15 high. And with that information, this is the referral. What should we do about his blood pressure? Is the 140/90 acceptable? Does he need to be investigated with treadmill tests, or should he have some atheroma imaging? And what do we do about his lipids? And so we all know that blood pressure targets have been shifting around a bit recently. We had some guidelines issued in 2014, which made us all sit up a little. And these have now been updated and revised, and the thresholds have shifted quite significantly, which I'll go through. The prevalence of hypertension is impressive. 1 in 3 adults have hypertension, and we know that it's an important condition, often regarded as the silent assassin. Causes heart attacks, heart failure, atrial fibrillation and strokes, aortic dissection, aortic aneurysms, intracerebral hemorrhage, renal failure, blindness, and the list goes on and on. And it's one of those silent conditions that you don't even realize you have. Just in terms of the guidelines, if one looks at 2014, this set of guidelines came out, and a lot of work was put into them. It was very evidence-based and based on sort of older trials, etc. They came up with this as a target for the diagnosis of hypertension, and that as a goal for treating hypertension, which made life quite simple. 140/90, and that was that. But a lot of us sat up and said, well, actually, that doesn't seem right. We've sort of been going for 130s and 120s. And the other important thing was in that older age group, they were accepting 150 suddenly. And, there was a lot of debate and unhappiness, various different bodies, diabetic associations, renal associations, hypertensive associations. This is ACC. Kind of argued about these, and so it stimulated more work and led to the sprint trial, which was really underway by the time that guidelines were published, but they were looking for the appropriate targets, and it's an excellent trial, this. Lots of patients, they were fairly elderly, 28% over 75, of high risk, 70% were sort of in that high risk category, and they had two arms in the trial. An intensive arm, and they used drugs to lower blood pressure to sort of less than 120, and then the standard arm 140. And during the trial, they achieved those goals. One can see that the intensive group required more drugs, up to 3, whereas the standard treatment group had between 1 and 2 drugs. And the important thing was that they did achieve these different blood pressure targets during the trial, and this is the outcome. Significant differences in all-cause mortality, and also in a combination of cardiac endpoints such as acute coronary syndrome, stroke, and cardiovascular death. And as a result of these results, the trial was actually terminated early because of this huge difference, particularly in all-cause mortality. And so the updated guidelines published towards the end of last year have now shifted the goals substantially. Ideal blood pressure is now 120/80. Elevated is anything above 120 to 129/80. And then we have stage 1 and stage 2. And so our patient immediately fits into stage 2. Ideal is 120/80, and that's where he fits, even though he's so young. One of the very important aspects that are mentioned in these newer guidelines is that one has to measure blood pressure accurately, and as you know, it's a very variable measurement. And what they suggest is that one starts engaging the patients more and getting them to do home blood pressure monitoring. So purchase a cuff which fits the arm, and get them to do home measurements. And what they recommend is that the patients take their measurements in a sitting position with the arm rested, and they should do it when they are relaxed, and they should do 3 measurements every time and take the best out of 3 and jot it down, and then average 12 or 20 measurements. And that's how they did it in the sprint trial. When the patients came to clinic for their follow-ups, they were actually put into a pleasant environment, and they did their own measurements and then presented them back to the investigators. And so that's the sort of method we are now postulating. The other important thing from these guidelines is that one shouldn't interpret the blood pressure in isolation. One should interpret it in the context of the patient's cardiovascular risk, which is what we do for lipids anyway. And so if one has someone with a blood pressure of 140/90 and they are of low cardiovascular risk, then one would sort of be pushing the non-pharmacological side much harder. Whereas if you've got a patient similar to this who's intermediate or maybe high, one would start looking at medication. I just thought I'd list these trials which have really shown the benefits of home blood pressure monitoring versus clinic monitoring in predicting cardiovascular events, demonstrating that home measurements are actually a better way of doing things in hypertension. And this is a flow diagram out of the guidelines, and just to focus on our patients. So by definition, 140/90 and equal would be stage 2, and he immediately goes into this non-pharmacological and medication limb, gets reassessed after a month of treatment, and then up-titrated and seen every 3 to 6 months, depending on how he's doing. In terms of the broader scheme of things, a lot of our patients are going to be in this sort of situation, 130 to 140, and they potentially are going to be of sort of a lower cardiovascular risk, in which the case they're going to go down that sort of non-pharmacological limb. And equally, if they're in this range and they are of high cardiovascular risk or higher cardiovascular risk, then that they'd come down here, and one would consider medication. And so it's just working with the patients, demonstrating their risk, and getting them to use home monitoring, which is going to help a lot here. Just to give you an idea of what we can do in terms of lifestyle to lower blood pressure. Diet impressively lowers blood pressure as much as any of the good medications we use, etc., all the way down. And then, onto our gentleman. He had no clinical evidence of cardiovascular disease, 10-year risk of less than, or his 5-year risk was less than 10%. So he kind of fits in here, and we should be targeting him around 130/80. And as that guideline said, if he, he may well require medication to achieve that sort of target. The other important group, as I mentioned earlier, in the old guidelines, we accepted 150 for this age group, the 65-year-old. And this is no longer the case. We're now targeting their threshold at 130 and trying to achieve a blood pressure of less than 130. And these are guidelines. We're not asking you to take your patients and give them drugs that they aren't going to tolerate and get ill on and get dizzy on. But I think one's just got to bear in mind that one's sort of working towards this sort of target and not a 150 target. And this is something we often hit, is this reluctance to be on antihypertensive therapy. And the SPRINT trial showed us that if you reduce, his blood pressure by 10, potentially we could reduce his relative risk of having some form of cardiac event by 20%. So that potentially could help you, get the buy-in that you want. And the other way we do it is by doing some atheroma imaging. And so we have some data on calcium scoring, and this is the SPRINT trial, a sample out of the SPRINT trial that had intensive therapy, and this green arm where one sees that their risk of an event is greater is in the group that had a high calcium score of over 100 versus a normal calcium score. So one can see that if you're in this situation with even a blood pressure of 140, you stand to benefit a lot by getting that 10 millimeter reduction in blood pressure. And hopefully that, the patients will then kind of become more compliant and more willing to take their therapy. So just to conclude, the new guidelines will end up reclassifying a lot of patients. The prevalence of hypertension, they've estimated, will go up by about 15%. We're going to capture a lot more younger patients. And they stress the importance of home blood pressure monitoring and assessing blood pressure results in the context of the cardiovascular risk assessment. And just don't forget about the elderly, where that threshold has come down. This is an important concept as well. One really wants to catch this group 120 to 140 and alter the lifestyle, get them exercising, get them losing weight, eating healthily, lowering their alcohol consumption, and thereby will manage them and prevent them from becoming true hypertensive, requiring a lot of drugs and having a lot of cardiovascular events. Thanks.
Thanks, Colin. And the idea is that we'll have 5 minutes at the end to answer some questions to both of us. How do you get people to drink less? That's a real problem, I've discovered. Colin touched on it, and I think this whole area of primary prevention in cardiology, one of the big problems is persuading patients to take the blood pressure pill. And if it's hard enough to take the blood pressure pill, they don't want to take a statin. So I found it very helpful to just go back to a couple of basics of what is the mechanism of harm, explore that with the patient, and they get it, they understand it. So we know that many of us will have atheromatous streaks and early atheroma. In fact, very few of us don't get any in our life. And the mechanism of harm, we understand, is that you rip and tear a vulnerable plaque and then a blood clot forms which can potentially block your artery. And if it blocks it around the heart, you have a heart attack, and if it blocks it around the brain, you have a stroke. And people sort of can understand that concept of fat laying down and weakening their artery. And then if we talk about the vulnerable plaque, the large amount of, or the weakened wall of the artery, as so. And then how do statins work? Well, if you want to lower the cholesterol, what the statin does is that it toughens up the weak wall. It makes it more fibrous. What actually happens is that as the cholesterol in the blood goes down, we leach out cholesterol. The space is covered by new cells coming in and laying down collagen. So you end up with a more fibrous, secure artery. And if you talk to patients about stabilizing the aging, weaker arteries, they get it, they understand it. And I found that highly effective as number one in a simple way to try to start off the discussion about should they take a statin. And so we know that statins stabilise plaques, reduce vascular events. Do they really work? And do they work long term? Well, they do really work. And I think most of us are converted, but not everybody in the community is. This is the statin paper, 170,000 participants, 26 randomised trials, the cholesterol trialists, all of that data put together in Oxford. And this is in a similar way to what Colin was talking about, the 20% reduction. Statin therapy safely reduces the 5-year incidence of major cardiovascular events by just over 20% for every 1 millimole reduction in LDL cholesterol. It's sometimes worth us just remembering that. It's actually a powerful thing to do, just 1 millimole. So 10 millimeters of blood pressure drop, 1 millimole of LDL cholesterol drop, 20% for each. But in fact, for statins, there was no evidence of any threshold, and there is still no evidence of any threshold. And later on, we're going to chat about that a little bit more. And so if you lower the LDL by 2 to 3 millimoles, you will reduce the risk by 40 to 50%. That is quite important and stunning to remember when we're struggling to get people to take these pills. And I should just note that all of these slides will be available on the web at the end of the conference. You'll be able to just look at it from our website and look at the slides. So who's heard about the 20-year follow-up of statin trials? This was anybody? No, it's a very... we know that a large number of trials run for 5 years and they stop. And then the question is, well, what happens after that? And the West of Scotland trialists went back 20 years later and found out what happened to their population. The full study came out in 1995 when I was a fellow at Green Lane, and it was a fascinating study, 30% reduction, and statins obviously worked. Well, the trialists went back and they discovered, that at the end of the trial, the local general practitioners in Glasgow put 30% of each arm on a statin, so the groups were now balanced. And then they were followed up 20 years later. So this is the initial trial, placebo statin, it was pravastatin, vascular events, time. So the placebo sort of went like that, and you'd sort of hope that there'd be a parallel there, that you'd done some good and it was maintained. You might think, well, gee, it could drift back to there, in which case you've got that benefit under the curve, area under the curve as benefit. But in fact, what happened was quite staggering, that the curves continued to diverge. So what you did in the first 5 years, even though the population was now balanced, you actually did some good in those arteries long term. And the concept of statin legacy was born. And all-cause mortality, cardiovascular mortality, coronary heart disease mortality, these are diverging curves. You imagine what would have happened if we'd had them on the statin all the time. Well, you can only guess, but statin legacy, these are powerful medicines. And of course, does it cause cancer, make you leap off the cliff? No, it doesn't. There's no increased non-cardiovascular mortality with statins. They are extraordinarily safe. So how do you get patients to take these things? Well, and how do you assess risk? Well, traditionally we've used epidemiology with complex equations. There's a huge numbers of these around the world, and the standard was Framingham, but things have moved on from Framingham. Trying to work out the impossible, really, predicting risk for the future. But over time, it has been realised that although these are useful, even the best models aren't accurate. They're quite inaccurate. The New Zealand model is changing again to try to tighten up and try to become more accurate, and that's all good. And in fact, it's a reasonable way to start, because then it focuses people on the risk factors that you can do something about, that's all well and good. But in fact, most of atheroma, an awful lot of it is just driven by genes in the environment, which we don't really understand. And is this really good enough going forward? And does it convince patients to do as you would like them to do, to take medication? And that's really where the field has moved on. Imaging-based is clearly a more efficient, accurate, and actually, from the patient's perspective, much more understandable way of appreciating what risk they're at. So if you look at calcified coronary arteries, it's intuitive. If you look at your arteries and you find that you're aging them, and gee, you're aging them a whole lot quicker than the neighbour next door, well, that's quite revealing and very motivating. The concept is used elsewhere. If you want to know if you've got breast cancer, you don't look at charts on the wall or punch figures into the computer. You actually do a mammogram. The end product, this is the issue, that there's so much we don't understand about atherosclerosis, if we're really honest with ourselves, genetic and environmental risk. But the end product is whether you're actually aging the coronary arteries, the carotid arteries, the femoral arteries. Overseas, people have scanned the femoral arteries and find that's a very good predictor of risk, and it far outstrips the epidemiology. So this is a useful tool to use, and we're increasingly using it. So, and it's fairly straightforward. There's a LAD circumflex, there's an LAD circumflex. One's got a lot of calcium, one doesn't. So this character has got a lot more atheroma, a lot more risk. And if we then look at how you put the slices across the chest, circumflex, LAD, right coronary artery, you can slice all the way through going down the heart, and this patient's got no calcium. This patient is at low risk. Whereas this patient, let's say he's our character that we're talking about, our 48-year-old, he's got a heap of risk, calcium everywhere. And you can get a score, you can put it on the table, you can show him an image and say, this is happening in your artery. You have an opportunity to stabilise those arteries. Would you like to take it? And it cuts through an awful lot of sweat and worry and statin phobia if you can actually show people the reality of what's going on. What's the science? Well, the science... Colin's already demonstrated with one of the studies. Again, there's a heap of this. The MESA study, in fact, last time I looked at this is the multi-ethnic study of atherosclerosis funded by the American government. You can go to their website and you can look at 800 papers. There are now 800 papers there. This is one of the early ones, looking at cumulative incidence of coronary problems, coronary events versus time. And if you've got a score of 0, you're extremely low risk. If you go up to 100, you're at higher risk, up to 300, high risk, above 300, even higher risk. It's a very accurate way of assessing risk. We've done this locally. Some characters here you all know. And we looked at our Mercy cohort who went through, and we worked out their Framingham risk with the adjustments as they were in those days. Low risk 0 to 10, 10 to 15, 5-year risk, 15 plus 5-year risk. And then they'd already had a scan of those with 0 going up to those with a score of more than 1,000. And look at this low risk group. 22% of that low risk group, actually we are inadvertently advising that they're at low risk. They're actually at high risk, but we just didn't know. And so and if you look at the other end, in fact, those that should be at high risk, in fact, some of them are actually at quite low risk. So this identifies, cuts through an awful lot of we didn't understand, and gives you a tool with which you can persuade patients to go down the line of appropriate medical management to preserve them. And all for the cost of 1 millisievert, which is the same as a mammogram. It's a safe screening tool. The background radiation dose in New Zealand is 3 millisieverts. So we were tasked with a fairly improbable task of 25 minutes to talk about primary prevention in cardiology. So I would like to remind you that we have focused on two areas. The lifestyle methods, and particularly across the population, are hugely important, and we all struggle with that. We're all clinicians, and we all struggle with trying to improve it. And in fact, it's not just with our patients, we try to struggle with ourselves as well. I mean, how many of us get out there and walk 5 days a week? Well, I won't ask you to put your hand up. And for medical methods, we focused on two of those for the sake of time, and to try to bring you a couple of areas which we thought would be of more interest than some of the others. Imaging methods, they're not available for everybody, but they're increasingly going to take off, and whether you image the calcium score or whether you image other arteries, that's the more accurate way of assessing risk when it comes to it, and it's so much easier once you've got that to then talk to a patient. And there is compelling scientific evidence, I think we all are aware of, that morbidity and mortality from vascular disease is reduced by improving all of those factors. And really that's what we struggle with and want to work on when we go back to the clinic on Monday. So we'll stop there and just turn the lights on, or in fact we won't turn the lights on. I think we'll take a few questions and until people have had enough, until we're told to move next door. Please, go ahead.
I've got a patient, he's Maori Indian descent, he's 55, he's been on a statin since he was 25, so he's been on it for 30 years, because his cousin dropped dead of a heart attack at 33, something like that.
Right.
And now he's talking about wanting to come off it, so would he have an indication to have a CT scoring or not?
You certainly could. I'd work on the other angle and say, man, your cousin dropped at 35 and you're now 55, and do you suppose that these pills have probably got you there? You've stabilised your ageing process all the way through. Don't be, and then you've got to try the persuasion technique. Look at his family. He's got 3 kids. Do you want to see them go down the aisle? Do you want to see your grandchildren? Can a calcium score help? Yes, it can. It'll tell you how much calcium he's got. In actual fact, there's a very slight increase in calcium when you put people on a statin, because what you're doing is you're actually encouraging repair. You're encouraging repair. And the reason that calcium scoring is so accurate is because probably you're picking up the cohort who are actually plaque rupturers. Some of us rupture plaques, others don't. Why is that? Who knows? It's genetics. But actually the repair process is calcification. That's why it's so accurate as a test. And so in fact, when you put people on statins, there's a very slight increase of calcium because you're encouraging repair. You could certainly you keep that to yourself, so to speak, but you could certainly put him through, and very likely he'll have a high calcium score. You've encouraged repair plus his natural plaque rupturing.
Yeah, his cholesterol when he was 25 was, I think, 10, 9.
Well, I just say, get your head in and to carry on taking them.
Yeah, that's fine. I just wonder if there's any benefit from having a CT.
Only in the sense that it's very likely to be high, yes. And then you can say, look, this has stabilised you, this has protected you all these times, carry on. Yes. So yes, you could, but it's not really the cohort that we're looking at, and I personally would be using other methods to try to persuade him.
Yeah.
Any other questions?
What age should you do the CT score in somebody growing up whose father's got dreadful CT score? When do we start? I mean, if we know that the 60-year-old has a terrible CT score, when should we be looking at the siblings?
Colin, come on up and.
So, if one looks at the current guidelines, the guidelines say one should start risk stratifying high-risk families. I think males from 30 and females from a slightly older age. I think it was 35. In general, the average Joe Soap, one starts screening at 45, yes. Females at 55. I must say, I don't do too many calcium scores in people under the age of 40. I don't know about you, Chris. And then, I think if one does one at a young age, and it's normal, perhaps one should repeat it 5 years later just to make sure, that this person at a young age who's had a normal calcium score isn't developing plaque, if we haven't started statins, etc.
So the 60-year-old didn't have risk factor other than having had father have heart disease
Yeah.
and had a cholesterol within the New Zealand norm,
Yeah.
but not a lovely LDL.
Yeah.
And that's my ex-husband, and I
Yeah.
have children. One is a doctor who's
Yeah.
about to be 30,
Yeah.
whose cholesterol is almost ideal. It's 2, LDL of 2, and on a non-good diet.
Yeah.
And we're just going, how much do you carry your father's risk? And we know his father had lipoprotein A, but it's all of
Yeah.
what age do you start being really strict on that they want to be so much more strict in their lifestyle?
Yeah, I think that's the important take-home message, that from a young age he has looked after himself, has exercised,
So
has
it's
had good
so
dietary
hard.
advice, and then perhaps over the age of, from the age of 40, 45, you could get a calcium score if you really want to know, where you're sitting and what you're tracking.
Well, I mean, it's just
Yeah.
whether you run your
Yeah.
LDL at 2 or whether you run your LDL at
Yeah.
1.6.
Well, yeah, that is. There's no harm if somebody really wants to know. You can do it earlier. It's 1 millisiever. You can do it
Yeah.
earlier.
Yeah.
And in fact,
I'm
very
just
often in the
wondering how
younger.
earlier it is.
Yeah, well, I mean, if he wants to do it 30, 35, you could do it because it's a safe thing to do. It's likely to be normal at that stage. The other thing you can do is you can scan the carotid. A lot of early atheroma before it calcifies, you can see in the carotid. And so sometimes I combine the two. Like Colin, I'm reluctant to do too much screening too young. And it's an open question for the normal population. 50, 45, who knows? I mean, it depends on the family history, it depends on your other risk. But if you go a bit earlier, as long as you do it again 5 years later, if it's negative, if it's normal, then that's a reasonable thing to do. But, I actually went for mine at 50, and as I was coming up to it, I was thinking, gee, I should have done this earlier, I should have done this earlier. So it's an open question, and we will discover more as the time goes by.
No, I understand.
Yeah. Yeah, understood. But I mean, I certainly, there are some people who come in and insist on having it done, and then we respond to that. It certainly buys them into the process. They're back 5 years later, and then actually several of those I'm now discovering, yes, they've then got calcium 5 years later, and then we're much more proactive. So I think Colin and I we probably have to move, so we'll take just one last question, then we've got to go.
For patients that are absolutely intolerant of statins, what's your next best?
Come to the session in the second session coming up, because we're having a little chat about that, and I hope that will answer that question about what to do about the patient who really doesn't want to take statins or can't take statins. So thanks for coming, and I hope that we've touched on a couple of areas of some interest for your patients. Thank you.